Hello, so we are the Old Souls. My name is Mikaela, and my group members are Shannon, Mariah, Talley, Rachel, and Emily. Our project title is Virtually Reaching Rural Caregivers, or VRRC, as we will be referring to it throughout our presentation. The goal of this project is to effectively translate the RCI Reach program to a virtual platform for rural dementia caregiving DYADS. RCI Reach stands for Rosalind Carter Institute, Resources for Enhancing Alzheimer's Caregiver Health. This project is part of the OT 631 course, Program Assessment and Development. So, to start this project, we first conducted a needs assessment. This involved collaboration with our community partners, the main one being the Center for Community Partnerships at CSU, more specifically Julie Silver-Seidel and James Graham. We also worked with Cheryl Noble and Sue Schneider from Senior Access Points, as well as Andrea Francois from EverHuman. For our needs assessment process, we followed the phases and steps from Altschutz and Kumar. We conducted primary and follow-up interviews, conducted an extensive literature search, and engaged in group discussion to identify and prioritize needs, as well as conduct a causal analysis. We also presented our needs assessment and received an integrated feedback from our community partners. From this process, we identified 4 significant needs. Our first need, and truly the heart of our project, is a lack of sufficient support and education for dementia caregiving DYADS. Our second need is a lack of trust in rural communities. Rural communities communicate differently than urban communities and often place more trust in important community members or gatekeepers rather than outsiders. Our third need is the reduced access to healthcare resources. This has to do with the remote location of these caregiving DYADS. They have to travel farther to reach doctors or other healthcare services, and their internet access for online resources can be iffy, or they're just not familiar with how to use it. Also, services such as respite care that may be used in urban areas are likely unavailable. Lastly, there's currently no virtual platform for the RCI Reach program. This evidence-based program has shown very promising outcomes, but currently only exists as an in-person or over-the-phone program. Through discussion with Julie and reviewing the NIH grant that CCP has drafted, we felt this was the area we could most effectively fit in and help to develop. This need is currently heightened as well due to COVID-19 and its effects on in-person services. Now Emily will discuss occupational performance and participation.
Thanks, Mikaela. So first, it's important to understand that the American OT Association defines occupational engagement as performance in occupations as a result of choice, motivation, and meaning within a supportive context and environment. We want to consider this both in context of our service recipients, the caregiving DYADS, and our service deliverers, the folks at CCP who will execute the VRRC REACH program. And these images below are trying to portray some of the daily life occupations of caregivers and their loved ones. High frequency ADLs such as dressing, bathing, and functional mobility make up a large part of the day, as well as IADLs, which really come down to running a household, such as money management, meal preparation, and arranging care for loved ones. Are the bulk of what these individuals are doing during the day. And all while having these responsibilities, they are problem solving to maximize their loved ones' independence, despite the progressive declines associated with their dementia. Caregivers have their own idea, values, and beliefs around what is best, how to best execute these daily activities. And the constant attention, observation, and judgment skills that they are having to have while looking after their loved one is compounded by the guilt and stress of, am I meeting my expectations? And am I truly giving my loved one all that I can? Considering this, there's not much time for caregivers to consider their personal needs. And that's an advantage of the VRRC program. Caregivers report wanting education and skills on disease progression and how to handle behavioral outbursts with their loved ones. In terms of our service deliverers, one thing that they report needing is a virtual platform orientation. This ensures that deliverers are confident in their abilities to troubleshoot tech issues that arise, but it also helps set up DYADS for success and engagement in our online course. Another need is that while modules will be pre-made, DYADS need to still be able to have their unique individual needs addressed. Ultimately, the VRRC program is about building trust, as well as education and skill building. But by not addressing these needs, the biggest cost is to trust. Rural community members will continue not trusting outside resources and medical providers. And by doing so, their needs will not be met, further driving social isolation, sleep disruption, and chronic disease-related distress.
So next, we will be talking about our program goal and objectives. So our main goal is to effectively deliver the evidence-based RCI REACH program virtually to rural dementia caregiver dyads in Northern Colorado. As you can see, this is our timeline that we have for each of our objectives, and we will be going more in depth about each objective and the timeline in our next couple slides. So objective one is participate in standardized RCI REACH coach training within months 1 through 3 of our project. The evidence to support this objective is that coaches must have 80 hours of training and a bachelor's degree in psychology, social work, nursing, occupational therapy, or other related discipline, and have knowledge about dementia symptoms and the challenges associated with dementia caregiving. This evidence is important so we can successfully and effectively reach our intended outcomes for this objective. The activities associated with this objective is we want to make sure to interview qualified candidates for the RCI REACH coaching positions. And then after that, our second activity will be to train staff on RCI REACH coaching positions. The intended output and outcomes of this objective is to have 2 CCP staff members trained in the RCI REACH coach training program.
Our next objective will be the actual creation of the virtual integrative protocol within months 3 to 15 of our 2-year plan. The evidence supporting this objective is that the virtual protocol is needed due to the rural difficulties related to distance from healthcare services, and there is a need because RCI REACH does not currently exist as a virtual platform. The virtual protocol will be convenient for caregivers as they support their care recipients in their own homes. To complete this objective, we will first create these RCI REACH modules and translate to virtual platform, which will include the creation of pre-recorded educational video sessions that describe dementia progression, home modification tips, and basics on managing behaviors. We will also create a group educational module for monthly group meetups, outlining the structure of these group sessions. Second, we will seek approval from the originators of RCI REACH by sending them a draft of the VRRC program to ensure adherence to the RCI REACH mission and model. Third, we will train staff on VRRC protocol and introduce sustainability strategies to reduce staff burnout and fatigue. And fourth, we will create the Zoom orientation modules for DYADS consisting of short explanations of Zoom basics, virtual etiquette, and how to successfully participate in group meetings. In the actual implementation of VRRC, live follow-up sessions will be held to work through caregiver questions they have during orientation. To summarize, the outputs and outcomes of this objective will include the creation of virtual protocol and specific modules, approval of VRRC protocol by RCI REACH, training of CCP staff and fieldwork students, and the development of orientation materials.
Then the third objective, in order to successfully implement this program, is to recruit 8 caregiving rural dyads during months 15 and 18 of the 2-year timeline. It is essential that this objective takes place in order to run a feasibility study to understand the effectiveness and the sustainability of the VRRC program. So the first activity will consist of connecting with key gatekeepers within the communities identified by senior access points, support groups, as well as the Center for Healthy Aging at CSU. Key gatekeepers are defined as trusted persons in the community who provide a service of some kind. So this can include librarians, firefighters, newspaper editors, anyone that's providing a service that these individuals in the communities trust. The second activity will be to create individualized recruitment materials that will align with the community's preferred method of communication. So this could include flyers, word of mouth, radio ads, and/or video and resources in the local libraries. And then once these resources are created, they will be dispersed to the gatekeepers. And then once DYADS have contacted the VRRC program and have expressed interest, the VRRC coaches will conduct an intake interview in which these caregiving DYADS will discuss their concerns, the reasons why they agreed to participate in the study, and also provide some information about their environment, which can include their location, as well as their access and comfort level with internet-based platforms such as Zoom. Then the last activity for this objective will include tracking recruitment efforts in order to identify any gaps in the efforts. This can include recording the number of responses, the number of DYADS that were screened, as well as the number that were enrolled, and how much time it took to enroll participants. Then the primary outputs and outcomes of these activities are the development of the recruitment materials and the successful recruitment and enrollment of 8 caregiver DYADS in order to participate in the VRRC program. Recruiting 8 of these DYADS would suggest that trust has begun to be built in these rural communities.
After we have recruited all 8 of our caregiver dyad participants, we will begin with objective 4, which is to determine the feasibility of the virtual reach VRRC program using a very small pilot study during months 18 to 24. Research supports this objective as there is still emerging translation of evidence-based interventions to more community programs. Additionally, this is the first study to combine the benefits of virtual programs and the RCI REACH program. Therefore, a feasibility study is a cost-effective way to test and modify the VRRC protocol as needed before the NIH study that you all at CCP proposed gets started. So the first activity will include the 8 caregiver dyads participating in the virtual orientation Shannon described in objective 2, as well as completing baseline measures of ADL knowledge and confidence, as well as a multifaceted quality of life measure. In the second activity, participants will engage in 6 VRRC sessions in which they will receive individually tailored information based on the baseline measures, as well as the intake interview Rachel described in objective 3. This is a typically done process in other RCI REACH programs, and we believe it'll be effectively done virtually. The information that caregiver dyads will receive involves safety, caregiver health and well-being, social and peer support, as well as problem solving. In the final session, the caregivers will be asked to complete the baseline measures again, as well as participate in a satisfaction survey, which you can find in the PDF of references we had emailed out. Additionally, the VRRC coaches will participate in a similar but slightly different satisfaction survey as well. There's a list of other feasibility measures we will be using, and together we will analyze all that qualitative and quantitative data to assess the effectiveness of the pilot study, as well as make any changes to the VRRC protocol to enhance its satisfaction and effectiveness. To summarize, the outputs and outcomes include pre and post measures of the quality of life and ADL confidence measure, satisfaction surveys from both caregiver dyads and the VRRC coaches, as well as other measures of feasibility. Now that we've gone over all of the objectives, we'd like to just briefly summarize with the logic model. Shannon is going to go into further detail regarding the resources and inputs for this project. We have summarized the activities, outputs, and outcomes through this PowerPoint, and you have the logic model for reference as you need. Lastly, we just want to place a big emphasis on the impacts that we believe this project will have. We believe that through VRRC, there will be improved trust built between rural communities and service providers. We also believe there will be empirical support of improved caregiver outcomes after engaging in the VRRC program. And lastly, we strongly believe that there will be improved access to services for those rural caregiver providers who otherwise would not have the same level of services.
The most important inputs to help make VRRC a success are the partnership with CCP, which helps with the sustainability of this program, the NIH grant submission and the funding that will come with that, and CSU OT fieldwork students. A detailed description of our budget will be displayed on the following slide, but the main chunk of costs for the VRRC program include paying the OT supervisor, the CCP staff member, the startup fee for the RCI Reach program, an annual renewal fee for RCI Coach, Zoom account designated to CCP, and any additional tech equipment we may need. The next slide shows the actual rundown of each component of the VRRC budget for you to reference. Thank you for listening to our presentation. Thank you to Aaron Ekman, Julie Silver-Seidel, James Graham, Sue Schneider, Cheryl Noble, and Andrea Boisois for being resources and a valuable part of our needs assessment team.